Welcome back to the Functional Code. We are excited to bring you guys today a new episode. We are in our core series. This is where we take a long form podcast and we break down just the gems, the nuts, and the bolts. We're going to be talking about spinal instability today. And before you're like, that sounds boring, I don't know if I want to listen to that, we're telling you this is going to affect more people than you think. A lot of the times people think their stiffness is just due to tightness, but could it be due to the fact that you have too much looseness in a way? And
yes.
We're going to break down what that means. And when we start going through the list of things that can cause instability, most will be on there. I know most of you listening will at least have one thing on there. And a lot of the times, instability is usually the reason why patients are having pain, they're not recovering, and they're not getting better. And so we're going to be breaking all that down today. As always, I am Dr. Addy.
And I am Dr. Jace. Yeah, going from looking at the spine, going to looking at to some of the other limbs, you can know how to test if you have this hypermobility and how it's affecting your system. So as we dive into this, I think it's important to understand the tightness, the guarding. Let's say someone's incredibly flexible, but they still feel like they're tight. This might be related to you.
Yep.
So as we dive into this, it's interesting. Like almost 80% of adults experience back pain, but yet fewer get assessed for this instability.
100%.
There's actually not many practitioners that actually look at some of this.
I think there are way too many who don't.
Oh, hugely.
And I think a lot of them are missing a true reason why patients are having their back pain. And there's so much research out there now showing what can cause instability. Anyone who has had a frequency ablation on their back has instability. Anyone who's ever fractured their spine has instability. People who are overweight, who gets atrophy, fatty atrophy of their multifida, which is going to be a lot, who are sedentary and overweight, have instability.
People have spinal fusions, surgeries.
Yes.
Up to 30 to 40%.
Yep. Have instability.
Yep.
Those who sit for long periods of time, those muscles will just get weaker, have instability.
Yes.
If you are too flexible, that could be unstable too.
Yes.
So
100%.
Again, there's a lot more that I think instability is really what's going on versus just tightness. And the tightness, Doc, if you want to explain, isn't the root. The tightness is because of the instability of guarding. How does that work? How does that happen?
So either it could be due to a past injury, motor vehicle accident, like whiplash. It could be due to sporting events, and you may have injured yourself, but the pain slowly went and got better, but there's still that underlying cause, and that underlying cause can last for decades long that you may not even realize.
Yep.
So all these small things, whether it's traumas, whether it's accidents, that can lead to this instability. Also, just genetically wise, it could also lead to instability where someone doesn't have certain proteins which allow for stiffness in the ligaments. Some tendons, depending on where they're attaching to.
Females can sometimes just have it too, right?
Yes. Yeah. More so than males on that side, yes. So it could be on a genetic side of things, it could be on an accident side of things. If you feel like you're in one of those two avenues, by all means, this could be you. Even for those individuals that were cheerleaders, dancers, gymnasts that were flexible at a younger age, but then stopped those activities as they got older, that could also be another cause as well, which is way more people than you may realize.
100%.
So there's this, what's known as stability triad that we're going to get into in terms of detection, correction, and then reinforcement, which will give you a good understanding of what is this actually and how we can go about looking at it and giving you tools to help already
100%.
On that side of things.
100%. So, Doc, let's start with just the understanding of the joint and how the joint can then trigger response in the tissues as far as guarding around it. And you want to just talk about the neurology of that a little bit?
Okay. So when you're looking at the joint, let's take, for example, the spine, because the spine can be, thank you, Doc, can be more cumbersome than most, especially for a majority of people. Now, when you look at the joints of the spine, for example, this is the lower back model. If you're not If you're just listening in, there's a model that we have, bone disc in between. The yellow is the nervous system, the spinal cord, and how the nerves come out of the spine. Now, the backside joints, and even on the model that you can see here, if those joints, if there's any breakdown, if there's any problem with any joint, it forces overlying muscle guarding, especially of the small muscle tissues, the multifidi, some the smaller connective tissues. Now, when that happens, if there's any problem, like I said, with the nervous system, it forces overlying muscle tightness. If you have that for longer periods of time and gravity always pressing down on our system, it leads to chronic muscle tightness at a deeper level, and it forces the muscles overlying it to compensate or take the brunt of the work. And that's where the tightness can then come in play. So when you're looking at correcting the problem, you have to look at a deeper level first, rehab from a deeper structure, and then work more superficial or more closer to the skin level, if we will. Going back to what Doc said, the neurology, in terms of how we're going about the rehab process, we want to start movement of the joints, and also, depending on for instability purposes, we want to address the ligaments on the back and front side of the spine. The anterior longitudinal ligament, the posterior longitudinal ligament, or ALL, PLL for short. And you have to be very specific in how you bleed, like this muscle contraction energy. Like when you're working out, it takes a lot of effort to move the weight, move the resistance. That energy can then get filtered into ligaments, tendons, muscles, joints. So it all depends on how smart you are in the rehab process from there. Now, certain physical therapists know how to do this, certain and fewer chiropractors know how to do this. It's all finding the specific one for you, and having the general understanding of what is going on for you specifically.
Yep. So detection, when we talk about understanding instability, is going to be, we got to look for it first, and you got to understand how to find it. And the most common, I would say, easiest things to pick out as a provider are going to be translations of the vertebral bodies on an x-ray. That's where most chiros who don't have a proper exam will at least hopefully catch it on the x-ray. But there are plenty of other examinations or orthopedic tests that you can do in order to pick out instability. And so if you don't have those built in to your systems, then you're not even going to be able to catch it in the first place. So there are breakdown tests that you can do for patients who have extreme hypermobility. That one is not really used, I would say, with every patient. That's just more if you expect it. Typically in the spine, the first things that we would look for would be hypermobility of the joint, or if there is chronic muscular tightness, kind of guarding mechanism, then we're already thinking, all right, is there instability at play, and then how would we look for that? So on an x-ray, what we're looking for, is there any translation forward or backwards of a vertebrae compared to the one below it? That is called either an anterior listhesis or a retrolisthesis.
Or a spondylolisthesis.
Yep, correct. Yep, sorry.
Yeah.
Yep.
No, you're good.
And that can be due to either a fracture that caused it to move, or there is instability, and that is causing a breakdown of that joint. But when we see that on an x-ray, then we are starting to think, okay, where is the breakdown, and how do we create stability around this unstable joint? And too often, I think it's missed. I don't think a lot of providers are good at catching them, because some of them are subtle. Some of it is what we call trace listhesis, which is, it's very minimal, but it's minimal in compared to what we see, but in the body, that amount of movement can still be quite substantial. And that even an MRI would even help give us more information. That is just some of the ways that you can check for instability. When someone is extremely hypermobile, you'll use what's called a Baton scale, and that is very quick to assess in patients. And each limb is considered a point when you are scaling or grading this. It's out of 9. So you take your thumb, and if you can put your thumb to your forearm, so let's say I could, that's 1 point. The next limb would be the second point. So let's say you could do it on both, that's 2. The next one would be being able to put your hand on a flat surface and bringing your pinky up to a 90-degree angle, okay? So that's number 3, and then number 4. And then next, if you put your arms straight out, and if you have a really hyperextension and you can see like a bent angle, that's the next point. And again, on the other limb would be the next point. Then if you're standing straight up and you have a hyperextension in your knees, let's see if that one's on there. Oh yeah, that would be that one. So that one, it doesn't really show it that well, but basically it almost looks, if you're standing straight up, your knee kind of locks backwards, and it's more posterior. That would be the other point, again, on both limbs. And then lastly, can you touch your hands, both hands, standing, bending over to the floor without...
Especially palms.
Yeah, palms. That would be a good one.
Yeah.
That is also the last point for number 9. So I believe over a 5 out of 9 is considered hypermobile, if I'm not mistaken.
I believe so.
4, does it say 4?
4 out of 9.
4 out of 9, excuse me. So 4 out of 9 would say, hey, you do have hypermobility. Then I would recommend you see either a rheumatologist or someone who deals with connective tissue disorders. They'll do blood work and other tests to just make sure to rule out what's usually diagnosed as Ehlers-Danlos syndrome is the most common. And just knowing you have it is a great next step to how to improve it.
Yes.
But if we don't know we have it, and believe me, we've caught many patients who have been to providers and they were never diagnosed with something like this, then their ability to train differently, move differently, protect themselves, reduce risk of injury, all these other things. Even in severe cases of EDS, there's visceral issues, heart and lung, stuff like that. So then they know what medications they might have to be on, all these other things. So
cold hands, cold feet would be a one.
Yep.
Could change position. Even leading to, Doc may have already brought this up, like POTS, postural,
100%.
hypostatic, was it
Postural orthostatic tachycardia syndrome. Yep.
Thank you.
Yep.
Appreciate you. So that's where, in terms of if you go from seated to standing or laying to standing, you have this dizziness. If you have some of that, in addition to some like blood, like vascular problems as well, that usually goes down the same rabbit hole as a postural orthostatic tachycardia syndrome. So
100%.
yeah, all those lead into this connective tissue to where there's a lot of instability of the spine and of the connective tissues and all the limbs, quite frankly, which can lead to all this guarding muscle tightness overlying.
And then the last thing I would say is just, again, that list of things that we noted with patients. Sedentary lifestyle, obesity, you've had fusion, you've had a fracture, you've had an RF ablation. These are all things that we're already going to guess that there is instability at either the segment or around it that you had the issue with. And that's where, once we pick that out, it's how we correct it. Now that changes because
before we get into that, I think this would be awesome. Let's say someone's going to a chiropractor. They may not check for instability, or you ask the question, Doc, have you checked? Is there any instability? If there's any hesitation in their answer, have them take flexion, extension views of the neck,
100%.
x-ray wise, and or lower back, because that can cause, and you might see this shifting, especially on what's known as the George's line, or the back side of the vertebral body. And if there's shifting greater than 2.5 millimeters, that's where you might have that instability there.
And I don't know if a lot do flexion extension, but that is usually the gold standard with seeing if that segment is extremely unstable or not.
Yes.
If there is a greater shift, like Doc said, then we really need to actually look at something more in the short-term urgency, because when we have an unstable segment, that can also cause neurological change, which we would never want.
Yes.
And that's where even a surgical consult might be necessary if there is a drastic shift. In patients who have a motor vehicle accident, we always worry about the top vertebrae shifting too far and creating neurological issues. That can also be caused by a fracture in the top part of the spine. And when basically the 1 and 2, C1 and 2 sits on top of 2, there's a peg that it's on. And when the peg can sometimes break due to a motor vehicle accident, that can cause advanced shifting of the C1 segment. That is also a warning sign that something severe is about to happen. and you want to get them to an ER immediately. And these are all things that doctors they need to understand post car accident. And I just find it completely odd where patients who are in motor vehicle accidents, they go into the ER, there's no imaging, they just get sent home, and there just needs to be so much more workup being done on these patients to make sure there's not anything that they need to be worried about. But we see it all the time, and I just would encourage providers to be more thorough in that case.
Be better.
Be better. Just be better.
Just be better.
So when it comes to correction, Doc, let's say we have instability at an area. What is the kind of concept and theory of rehabilitating the unstable joint?
Yes. First off, you want to figure out where and how it's unstable. And that goes back to the detection side of things. So once you notice that, let's say for example, there's a spondylolisthesis or anterosthesis, pretty much the same thing, just different terminology, where one bone is shifted forward on top of another, and then there's a difference. Oftentimes, you may have disc irritation going backwards, whether it's spondy-anterosthesis or even retroesthesis. So you also want to make sure that you are doing certain neurological tests to see, is there irritation, impingement on some of the nerves affecting the extremities, arms, legs, locally, sensation across, especially with the dermatomes. Depending on certain levels, and even with that, you would first want to start with isometric contractions or locally squeezing that specific area. So for example, whiplash, incredibly common, usually happens in the mid-neck, anywhere from C4 to C7, T1-ish area. Now, if there's like that shifting forward, first thing I usually start people on is what's known as the deep neck flexor holds, where you tuck your chin to your chest and you lift your head up off the ground if they're laying on their back. Now, why is that important? First off, it's going to force a little bit more tightening of the ligament on the backside, and it's also going to help strengthen the muscle longus cola on the front side. So automatically we're starting to bring, if the bone's sliding forward, to bring it back and to stabilize it. Thus also the rehab process, we're starting it on a neurological level, at a joint level. When we're doing isometrics and being specific, even if it's if you're laying on your back, putting pressure of your head back into the table and holding that pressure and then tucking your chin and back and forth like you're nodding with your head backwards for the most part. That will start turning off some of the muscle tension. Then you have to take into consideration neck specifically. Is there muscle pulling to the shoulder? Is the rib cage tilted, twisted? Is the rib cage coming forward and leading to more muscle pulling from the bottom of the chin to the sternum? That will also play effect because you have to take into consideration that. So then you would probably want to work with a physician that knows what's going on. But long story short, starting deeper level isometrics, deep neck flexor holds, so we can stiffen up and tighten up the ligament on the backside just to bring that segment backwards. Now, let's say, for example, there's a retroesthesis or the bone slides backwards. That's where you would have to address not only the ligament on the backside, but also on the front side, the anterior longitudinal ligament. So that way you could do this in a couple different ways, whether it's laying face down with your head up off like a couch table bed, and then tucking your chin to your chest, and then extending your head backwards, thus to tighten up the ligament on the front side. And then you can get into extensions or tilting of your head backwards. Depends on avoiding sharp pain specifically with all this, but those would be two awesome ways to start from there.
And so in a shortened concept, what we're trying to basically get you to understand is when you go to a provider and start rehab treatment and they start doing concentric reps that really just work the muscle belly, we're already missing the boat on an unstable joint, because what Doc and I are doing with patients is we are working at the joint level first, right away. That is where the instability is. And let's say someone assesses you, you have neck pain after a motor vehicle accident. maybe even shoulder pain after a motor vehicle accident, and there's more instability at the shoulder. If they put you on some exercises where you're just doing some band stretches and you're just lifting weights, doing all those kinds of things, there's no real target. You're not targeting the tissue that's the issue.
Yes.
And that's what we're trying to explain to you.
Stated.
We are trying to focus on where the actual issue is, and if you didn't already detect it, then you're already going to miss the boat. A lot of what Doc has created when it comes to his workout or his rehab program, which I have utilized now in a lot of what I've been doing, it is joint specific exclusively right away, and we maintain that throughout treatment, and we even encourage it post-treatment. Yes. Because we understand how important it is to keep our joints stable when we want to improve our life and continue on after the fact of rehab too. So that is where we're trying to shift this idea that when we even are training or even working out, we need to be training our joints more appropriately than our muscles at times, because that can even cause issues down the road when we don't put enough effort towards the joint. And yeah, that's what I got there.
Beautiful.
Yeah.
So we start locally, isometrics first. Now to get some of the overlying muscle tension to calm down, especially if there's, for the neck specifically, it's coming from upper back, shoulders to the neck. That's where we can get into kind of what's known as stretch contractions. There's other terms in terms of pales, rails. So you'd want to go into a stretch. Let's say, for example, there's instability, but to where some of the bones in the neck, let's say C5, C6, are going forward, anterior thesis. But there's muscle guarding coming from your upper back, shoulders. From there, we want to make sure that when we're going to some of these stretches that we're not causing any sharp pain, priority. So go into a stretch and then force a muscle contraction. For most people, if you would look down to your armpit, you hold the back of your head, and then you push your head into your hand without moving your head. So we're putting a contraction of myself trying to tilt backwards, but my hands resisting, thus without creating too much shifting. And this also goes back to what Doc said, concentric, eccentric movements in terms of like reps. That can also create that shifting, and that's not the target we're going for.
Yeah.
We're trying to turn off overlying muscle guarding, thus the contractions into the stretch. Ideally, from there, 10 to 20 seconds, and then put in your hand in the front, and then putting pressure without moving your head into the direction in which you're stretching. That can turn off what's known as this neurological tightness, where the whole muscle belly is contracted. And in order to get that to relieve itself, that usually stems from instability of a muscle guarding over a longer period of time.
It almost feels like you got a rope the entire way down your neck.
Really well stated. So as we're starting isometrics in certain positions, we can also add those in to turn off some overlying muscle tightness, but that comes into either you feeling in certain muscles in your neck. Does the whole muscle belly start from one side and attach all the way to where it inserts and where the origin is at? That's where most docs, practitioners have a general understanding in terms of where muscle bellies insert or not. If you have that knowledge base, you can assess this on yourself. It's a little more challenging, but you can start that process from there. So again, looking either to the armpit. Honestly, we're just trying to put whatever muscle that is, that ropey muscle, and put it at length or stretch, whether it's the muscles at the base of your skull, and then you would tuck your chin to your chest and do the same thing, head backwards, head forwards against resistance without moving your head. Maybe it's your upper back where you're rotating, reaching across your body without creating any extra movement, putting a contraction into the stretch and then away from the stretch. You can see where I'm coming from in terms of being specific and just lengthening each specific tissue. So those would be a couple of ways. You can also do, and a lot of the physical therapists do this, what's known as AccuStim, to where there's like an acupuncture needle into the muscle belly, and then they add in like electrical stimulator, which forces a muscle contraction of that muscle belly. That can work to a certain extent. The reason I don't lean towards that is you don't have the brain's connection to that tissue. So the rehab process can help for a period of time, but usually if there's that lack of connection, the pretty much the symptoms usually come back from there.
So you like more active
Yes.
than that just passive treatment. Is
Yes.
What you're saying. Yeah.
For certain times, for certain people, in certain situations, the AccuStim can work really well,
Yep.
or other passive modalities, therapies.
But longer term,
Yes.
we want an active engagement.
For most people,
For-
yes.
yeah.
Yeah.
Okay.
Yeah. Yeah, so that would be some of the main things in terms of starting where you would want to target. And even, like we said, starting at some of the deeper muscle bellies closer to the spine or closer to the joint, whether it's the rotators of the joints of the shoulder or the hip. That usually starts with rotational work. So starting just rotating as much as you possibly can one way, the opposite way, making sure there's no sharp pain. You change the angle of the limb, same thing. Rotate in, rotate out, maybe even adding in holding on to an exercise band of your hands or attaching an exercise band to your feet and then going and putting a long axis or a stretch and then going to rotation work can also work incredibly well. Depends on more specifics with that, but that's where you can start for deeper structures and work itself out from there.
Beautiful. Yes. I think the way that we create change in patients comes so much quicker once I've adopted this. And I just think that long term, this creates such better change.
Oh, yes.
And I think it's something that more people should be treated this way. And so I'm hoping more and more providers start to learn more from this because I do think it's going to change how they treat patients for sure.
Yes. Now, Doc, question for you. Proprioception, because I know
Yes.
you do a lot of work with this.
Yes.
How do you use proprioception? Because in terms of proprioception, that's where you feel like your body is in space. Now, that can often be one of the first things to diminish with spinal instability. So to regain that back, in addition to what we've already went over, Doc's an awesome resource.
There exists a high amount of proprioceptors around your joints.
Yes.
And so when we have a breakdown in the joint, we have a breakdown in proprioceptors. And those are things we also have to impact and improve after, like Doc said, a trauma or MVA or whatever. And when we are improving the joint, we also need to start practicing more proprioception training so that we can improve the joint health long term. Proprioceptors are also heavily tied to balance. And of course, if you've ever been injured, you've just noticed that you're less stable. Maybe you're not able to move as well as you used to. And so bringing that back to 100% is also needed once we've had a joint breakdown. One of the few ways that I would say we would do it in clinic is going to be balance stances. One-legged stances is a great way to start. Then we might add in some perturbation drills where I'm causing you to have to stand without falling over, so I'm pushing on you in certain ways. Then we can even do holded band work while you're balancing on one leg.
Good point.
Then there's angle changes where you can do tilted table where you're standing one leg on the side of a kind of an incline while you're trying to hold yourself up. And then we can even add in vibration platforms where that is also super stimulatory to the proprioceptors. And then if you're balancing while you're on the vibration platform, that's also a great dual kind of treatment. And then lastly, there are ways that we can challenge proprioception by closing our eyes. And so when we close our eyes, it causes us to increase proprioception more. We rely heavily on our proprioceptors when we are not being able to see. So we do a lot of exercises, eyes closed, to challenge the proprioceptors to improve our ability to feel. A lot of the times we have patients walking on PVC pipes or walking on unstable surfaces, eyes open and then eyes closed. That is also a great way to improve proprioception. If you look up proprioceptive training for shoulder, for hip, for back, these are all things that can pop up on YouTube for you as well if you're ever curious. But it is another facet of training that you should be adding into patients who have instability.
I love that.
Yeah.
Oh, that's beautiful. And even, Doc, you brought this up a while back, and I never thought about it from this point of view in terms of chiropractic adjustments
100%.
on how you can help the fast twitch muscles, especially the smaller muscles closer to the spine, re-engage. Do you want to touch on that?
Yeah, there was
specifically?
a neurologist that I was working with who talked a lot about this. He was one of the first to bring this theory up, and he had mentioned how chiropractic adjustment, his belief in what they were studying, when you are engaging and activating the smaller tissues around the spine. One of them would be the multifidi tissue. That can be activated. He argued that it can really only be activated in a few number of ways. And one of them is through fast rotation, fast rotation. And he goes, one of the best, obviously, ways to do that is an adjustment. And so, obviously, when we're adjusting patients, it's a very quick, controlled rotation, either in the neck, the upper back, or the lower back. And he argues that is one of the most powerful ways to activate those small rotators in the spine, and it does it very well.
And this is high velocity. There's definitely not oftentimes use a slow velocity where you kind of like slow mold the segments into place, but for most chiropractors, high velocity, what Doc is saying.
Yep.
Yeah.
And again, that's going to be a great way to improve stability, because those small stabilizers in the spine are really what we're trying to impact right away.
Yes.
More than likely, they've been turned off, quote unquote, after an injury. And there are times where they're off for a long period of time after an ablation, fusion, all these other things too. We need to be able to re-engage those, thus, if not, leading to breakdown in the spine even more.
Love that.
Yep.
Now let's take this a step further in terms of cars, workspaces, moving the joint through the fullest range of motion possible. Now the slight modification I would add for most people with instability would be if you can image yourself putting pressure against your hand, like when you bring your head backwards, it forces like this muscle contraction. If you can force that slight little bit of muscle contraction, but going through a very slow, smaller circle, it forces muscle contractions on everywhere and where you're rotating. Say, for example, if you're watching your neck, lighter contractions, forcing your neck muscles to squeeze as you're going through a smaller circle. Both directions, clockwise, counterclockwise, will also help stabilize and then bleed some of the energy to these small muscles of the neck. You can also do that same thing, squeezing your core or lower back muscles and then going through another smaller circle. Both directions will also help incredibly well.
And Doc, do you want to touch quick? I love when you brought this up. Why contraction is the key to changing the integrity of the muscle? Because a lot of people are like, I'm just going to stretch, I'm just going to move.
Yeah.
But why is the contraction the most important part when it comes to that?
It comes back to the connection from the brain to the tissues.
Yep.
If you're able, and that's one of the only ways that you're able to go about it outside of like the proprioception or putting your body in different positions and having it hold. If you're actively able to control that brain to body connection through squeezing a muscle, whether it's a certain muscle in your lower back, whether it's your neck, whether it's small muscle in your hands, fingers, that connection naturally allows your body to, and especially certain brain circuits to your brain cortex to be like, okay, it's safe to move in this area. I'm able to move in this area almost anytime on command, versus if you have overlying muscle tightness and you're just going to a stretch, you might stretch, it might relieve itself. There's some research that will help for long-term benefits, but the better use of everyone's time is to incorporate a stretch with a muscle contraction as you're stretching. Thus, so the body and tissues are able to communicate when they're already at length or being stretched, so they don't recoil back to what they're used to. Again, being able to control certain movements in different positions is the biggest thing from there.
So much heavier neurological stimulation with contraction.
100%.
Yeah.
Yeah.
Yeah, I love that. That has changed so much of how I am implementing handouts and exercises and giving patients just almost a leg up on what they're doing day to day with their exercises. And it's just so much more effective in my opinion. It's great.
Love that.
Yeah, it's great.
Gotta lean towards results, man.
Hell yeah, baby.
100%. Now, going back into reinforcement. So this is where, after we started to address some of the symptoms, let's say there's less muscle tightness, which is a really good sign to tell your body and tell you that things are starting to stabilize, that the muscles overlying aren't acting in place of the deeper structures. So once you notice maybe a little bit more range of motion, but more importantly, less tightness, less pain, discomfort. And then you can start ramping up the nervous system. You can start ramping up the certain exercise and going to length or eccentric work. So for example, for, let's say, for the neck specifically, whiplash symptoms, whether it's an anterior thesis, retro, or the bone sliding forward or backwards, doesn't matter too much. In terms of how we go about it, let's say we're heads hanging off the table, we tuck our chin to the chest, and then extend the head back, and then lengthen from there, or pretty much jut your chin up to the ceiling. You can bring that back to center, and then it turns into a slower type of movement. So the game and goal process is whether it's a ligament, whether it's certain muscle bellies, we want to slowly go to a stretch or slowly go into a lengthened state. So for the muscles on the front portion of the neck, tucking the chin while you're laying face down, and then extending your head backwards slowly works incredibly well. But taking into consideration that eccentric works or lengthening of any tissues creates a little bit more friction between certain muscle bellies, which can lead to you being more sore through some of these exercises. So that is completely normal.
Yeah.
Now let's say we want to add in...
Now, is there contraction with that?
Kind of. So it's almost like you're contracting the muscles on the back of your neck, but the more the focus is slowly trying to lengthen the muscles in the front.
Got it, okay.
Versus, let's say, we're trying to target the backside ligament, so the PLL. So the bone is either shifted forward and we're trying to bring it back. Thus, you can bring your head hanging off the table. You're laying on your back, laying face upwards. Having it hang off back to the side, tucking your chin first, and then slowly trying to bring your chin to your sternum. So it's almost like we're rolling and forcing this glide of our chin down our chest. As it's almost going to be like a sit-up, but for your neck. You can think of it that way. So that's a couple different ways. Like you can do some similarities with the lower back. Let's say there's shifting forward or backwards. You have a band wrapping around your lower back, and you slowly try to bring the band into stretch, or if it's pulling you from back to forward, you're trying to force your lower back into resistance, and then having your hand hold the band, and then you slowly allowing it to take your lower back forward. That would be another way. The main premise is lengthening tissues as the muscle tension is turning off, and then you want reassessment as well. Usually chiropractors are better at the palpation or feeling of certain bones and tissues than most other practitioners. So that's usually where we like to have someone monitoring as we're progressing through the reinforcement stage. But yeah,
I think the real benefit is still just going to be being able to practice this longer, maybe post seeing provider too.
Yes.
And that's where I think a lot of patients will see the change to understanding how to do these at home and away from the clinic, so that patients already can manage this by themselves without needing a provider too. But in the beginning, I think seeing a provider who understands this is going to just more than likely be helpful for you, so you can understand how to do it. There are docs who are really well versed in this. And what was the certification again, Doc?
Functional range conditioning specialist. Functional range conditioning, if you just look that up, there's on the top, they'll show locations. If you find any DCs, PTs, they should have a decent understanding on that side.
Perfect.
Yep.
Perfect.
Now for moving forward, so we have what's going on, how to start the rehab process for instability. Now with some of the AI stuff, because we're liking to add this AI component into it, there's not too many AI softwares, applications other than posture apps. So we're still early on that stage. Yeah. So that's going to be more to come down the road. I think if you can keep an assessment of maybe, let's say, X-ray to X-ray, or even range of motion videos can also help quite a bit in terms of when you first start off, take a video of your head going to flexion extension, lower back flexion extension, certain joints into certain ranges of motion. Take follow-up videos of that same exact movement, and also dictate how you are feeling, like maybe in a notebook, adding that video into AI, adding that notebook of the subjective of how you're feeling into AI. Long-term can give you a better understanding, so it can help you in terms of what other processes, what other exercise you can do to keep moving in the same direction. Again, I'd be cautious with some of the AI and being very tissue specific, but that is a way that you can go about it. Say you live out in the country, there's no practitioners nearby, that's maybe where I'd go.
For sure.
But yeah.
If not, does FRC have a lot of videos that people can watch too?
They're more of this, like the people that get certified, they have courses that they do on themselves. Cool. Look up someone, or even go to social media, Instagram, Facebook, YouTube, and then type in, okay, functional range conditioning specialist, see what pulls up, and then look at that person's page. They probably have follow-up exercises and guided tools from there.
And if not, Doc and I know he's been working hard on creating programs for people too. So that will also be hopefully coming
down the line.
Absolutely.
Whew.
Alrighty, is there anything else, Doc?
That was beautiful. I think we hit the nail on the head with the main stuff, how to go about it. So,
beautiful.
Yeah.
As always, everyone, thank you so much for watching. We appreciate each and every one of you. Please subscribe for more content. We are pushing it out every single week, and it's just been so much fun to be able to help each and every one of you. So please comment, leave us any notes that even if there's things in the future you want us to talk on, but so far we have just been extremely appreciative of each and every one of you. So until next time, guys, you guys have a great day.
Woo!
Disclaimer: the content provided in this health podcast is for informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. If you think you may have a medical emergency, call your doctor or 911 immediately. Reliance on any information provided in this podcast is solely at your own risk. The creators and hosts of this podcast are not responsible for any actions or decisions you may take based on the information presented.
Thanks for joining us on The Functional Code. For more evidence-based health insights, subscribe, rate and review wherever you get your podcasts. Remember, your journey to a healthier you begins with understanding the Functional Code. Until next time, stay well, stay informed, and embrace the science of living well.